Good morning. This is Mark Lichty. I'm chairman of Active Surveillance Patients International, and you're in good company here with the board that we have. We've all been through active surveillance. There's a tremendous number of years of active surveillance represented on our board, and our mission with all of you is to get you as comfortable as we are with this process of active surveillance. There's no reason for anxiety. I've been on active surveillance for 18 years, and it's been many years since I've dropped any anxiety around active surveillance. And so we really want to help you with your quality of life. We think we can all reach a level of peaceful vigilance in this journey. Now, I want to talk to you about another issue this morning that is an extremely important issue, and that has to do with Secretary Austin, who recently had prostate surgery. Now, I want you to know, all of you to know, I'm speaking on behalf of me. I am not speaking on behalf of Active Surveillance Patients International. I didn't even want to talk to them about this because it's kind of a controversial issue, but because I care so deeply about men not being overtreated and men dying unnecessarily of prostate cancer, I feel compelled to speak about it. And so we all know that recently Secretary Austin had a procedure, and secret procedure, really. He gave no notice about it. Now, I've already written to him about this. I received no response. So this appeal here this morning is a kind of a last-ditch effort to be heard on this subject. He is a public figure. He's Black. He can reach more people about this issue than anybody probably in the world. Black men die twice as much as Caucasians from prostate cancer. Black men have a lower rate of active surveillance uptake than Caucasian men. And what that means is that Black men are still being overtreated for prostate cancer. And so I'm speaking for me, I really reach out to Secretary Austin, and Godspeed in his recovery, but I reach out to him and say, please set an example that men can follow. And at the same time, Secretary Austin has an opportunity to redeem himself. By that, I mean he could apologize. He could apologize for putting our national security at risk. Nobody knew that he was doing this prostate cancer. Procedure. Nobody knew that he was going under anesthesia. He put our national security at risk. I think Biden deserves an apology. I think all of you deserve an apology for not being forthcoming. We need more candor in the world of prostate cancer. It's not an embarrassing thing to have prostate cancer, and it shouldn't be. It should be openly spoken of. And so that's why I really feel compelled to speak of this morning. And again, I want to all of you on this call, I really want to reinforce that there's a whole bunch of us out here that have reached a level of peaceful vigilance. If you're spending a lot of time on anxiety, on active surveillance, you don't need to. That's why we're here. With that, I would like to introduce our secretary. Martin, you're on.
Thank you, Mark. Greetings to everybody. Good day, good morning, good afternoon, good evening from wherever you're joining from the four corners of this planet. Welcome to Active Surveillance Patients International's first program in 2024. We're very excited, and I would like to very quickly present a couple of administrative points. so that we can get this webinar underway. Please know that this is an information webinar. Anything that is said or presented today that is of interest to you is not to be construed as medical recommendations or advice, but rather as an opportunity for you to discuss with your own medical team as you engage in an informed, shared decision-making process with your doctors. Secondly, we ask now, if you haven't already, that you turn off your cameras and your microphones. You won't need them at any time during this meeting. And it does become a major distraction for the speakers, so we sure would really appreciate it if you could do that. And lastly, please enter any follow-up questions you may have during the presentation in the chat box. You can access the chat box at the bottom of your screen, and you can put your questions in there. They'll be addressed during our Q&A session. Know that we can't address questions around your own particular medical situations. With that, I would like to hand this over to Geoff McLennan, fundraising chair on our ASPI board of directors and fellow prostate cancer patient on active surveillance. Take it away, Geoff.
Thank you, Martin, and thank you all for attending us this morning from wherever you are. I'm here in sunny Northern California for the moment. Today's program is Personalize Your Prostate Cancer Treatment with Genetic Testing. We thank you, Myriad Genetics, our sponsor, for providing us with the presenter, as well as Dr. Michael Glodé, who enjoys wonderful skiing in Colorado. Thank you, doctor, for being with us. Just a few words of introduction. Christina Nakamoto, medical science liaison for urology at Myriad Genetics, will discuss the benefits of medical grade genetic tests and how testing can provide personalized information about a person's prostate cancer. Michael Glodé serves on our ASPI Medical Advisory Committee, will join the discussion and field questions during the Q&A session. As we know, prostate cancer will be diagnosed in close to 300,000 men just in the United States and many thousands more in Europe, India, Canada, and the rest of the world. Men need to know about starting prostate cancer awareness and testing protocol with their primary care physician and other clinicians. Some doctors may begin tracking and testing you for prostate cancer as early as 40 years old. Thank you for joining us today, and I would like to begin the program by asking Christina Nakamoto with Myriad Genetics to take over from this point. Thank you.
All right. As Geoff said, good morning, good evening, good day, wherever you're currently in your part of the day. I'm in New Orleans, Louisiana. And as he said, I'm the medical science liaison for Myriad Genetics. I've been with Myriad almost 3 years. Prior to joining Myriad, I worked as a physician assistant in surgical oncology in the breast cancer space. Prior to that, I did medical oncology, so a lot of familiarity with treating metastatic prostate cancer patients and advanced prostate cancer patients. And I did do 1 year of ER, but I was not ER material. So oncology is really my passion. I have seen how genetic testing has impacted treatment decisions for patients, informed them about cancer risks for not only themselves, but their families. And I'm grateful to be here today. So thanks again for having me to give a little education and insight as to how genetic testing can impact your prostate cancer journey. Okay, I will share my screen now. Okay. Let's get started. So as Geoff just said, almost 299,000 cases are estimated to be diagnosed in the year of 2024 prostate cancer. Prostate cancer is very common. And this is in the United States. It's the second most common cancer diagnosis in men behind skin cancer. And 1 in 8 men in the United States will be diagnosed this year. Some risk factors, I'm sure some of you are aware, that can increase the likelihood of getting cancer are family history. So we often see many gentlemen within one family unit being diagnosed with prostate cancer. Race and ethnicity, this was touched on previously. African American men are at higher risk. We see the incidence of prostate cancer being greater in this population than others. And then genetic changes. So if we have an inherited mutation from our parents, these are just a couple. There are several that we test for, BRCA1, BRCA2, and then there are Lynch syndrome genes. These can all increase the likelihood of developing prostate cancer. Oops, I'm sorry. I'm trying to, okay. Screening. So again, y'all are all probably very familiar with how we screen for prostate cancer. PSA remains the cornerstone of screening initially. So if a PSA test is elevated above 4, that's going to kind of raise some eyebrows. Do we need to look further into what is causing that? There are a plethora of reasons that your PSA can be elevated, but prostate cancer is obviously one of them. A digital rectal exam where a urologist or a primary care doctor will feel the prostate for hard, lumpy abnormalities, anything that feels suspicious on exam. And then a prostate biopsy is where we remove prostate tissue and actually a pathologist will examine it to determine whether there is cancer in the tissue. So those are all the traditional ways that we screen for prostate cancer. But today we'll kind of dig a little deeper into some other ways to see if we're at further risk. So genetic testing reveals what you cannot see, but you really want to know about prostate cancer. And it allows patients and providers to make best treatment decisions based on those results. First, we'll go into hereditary cancer testing. So we know all cancer is caused by a genetic mutation of some sort, something from whether that be the environment, dietary, something that if we grew up next to a power plant, there's actually a city here in Louisiana, Bogalusa, where the cancer rate's like 35% because there's a huge paper mill in the town. And so we know it's doing something to the population. So it's causing genetic mutations, but those are environmental and not necessarily inherited. So at the top, that's what a somatic mutation is. A somatic mutation is a genetic mutation in a cancer cell that's only in the tumor itself. They can change over time. They can help guide treatment options. And testing is performed on tissue, sometimes blood, but that gets a little granular. Whereas germline mutations are inherited. So we get these from our parents. They are passed down from generation to generation, and they're found on every single cell in a person's body if they carry a mutation. So different from somatic mutations where they're just found in the tumor. If we were to sample any single cell of a patient with a germline mutation, we would find it in any cell of the body. They do not change over time. They also help guide treatment decisions like somatic mutations, and these tests are performed on either blood or saliva samples. So this breaks down prostate cancer and how we see it presenting via hereditary, familial, or sporadic occurrence. So most prostate cancer is sporadic, where we say it just occurs by chance. There's some statistic that if a man were to live to be, I can't remember the exact age, the probability of a man living to X age of getting prostate cancer would be very high. So again, it's mostly just a sporadic occurrence. However, we do see familial patterns, as I mentioned previously, where we'll see a cohort of men within a family unit, and they all develop prostate cancer. And these are likely caused by a combination of both genetic and environmental factors. So we have sporadic being the primary cause, familial being next in line, and then hereditary cancer is also a piece of the pie. So we know that certain men are predisposed to developing prostate cancer, having more aggressive cancer, and passing these mutations down to their offspring because they have a mutation that they've inherited from their parents. They're at highest risk, so they typically develop cancer earlier. As I said, it's more aggressive, and they're at risk for other cancers beyond prostate. And this is what we are really concerned about in our space, because if we screen properly, if we identify these mutations, we can help to prevent the development of cancer, and we can help to treat it most accurately in order to give these patients the best outcomes. So 1 in 6 prostate cancers are hereditary. That is really not that far off from breast cancer. Breast cancer, about 10% of breast cancers are hereditary. So breast cancer has made a lot of strides. We hear about genetic testing in that space frequently, but I think prostate cancer often gets left behind. And we think that it's not as, that prostate cancer patients aren't at a big of a risk as breast cancer patients for hereditary cancer, but that's actually untrue. If you have a gene mutation, your parents, your children, your siblings also could have a 50% chance of having that same mutation. Other blood relatives within the family unit are also at risk. So we're thinking aunts, uncles, cousins, etc. And genetic testing is we say the primary way, but really the only way to identify these gene mutations, which could impact your medical management. You can inherit a gene mutation from either your mother or your father. So it's important to look at both sides of the family. There are still a lot of misconceptions around this, even in the medical community. If providers aren't trained on this, that, oh, it's a maternal thing. You know, we're only getting these from our mother. That is untrue. You can get it from either side, because you're getting 50% of your DNA from your mom and 50 from your dad. So it can come from either side. So understanding if you're at risk for hereditary cancer starts with knowing your personal and family history. I know sometimes it's really hard to know family history, but the deeper you can dig into determining whether you are at risk based on family history, the better, because it can help providers really provide to you the best answers as to whether you may be at risk due to a genetic mutation. So certain tests like MyRisk, hereditary cancer testing, that's the test that we provide at Myriad Genetics. There are others on the market as well, offer peace of mind. They provide information to help your physician or medical provider customize your cancer care. As I mentioned before, these tests are the same type of tests that women with breast cancer receive and men and women with colon cancer routinely get to help inform and customize their treatment plans. So how do these benefit newly diagnosed patients? Well, say it does look like on your pathology and your PSA and your tumor stage and et cetera, all the criteria that we usually use to determine how at risk a patient is, say that it does look like you can safely pursue active surveillance, but you get one of these tests and it says, oh no, you have a BRCA mutation. It might allow us to reconsider whether we feel like we want to continue to pursue active surveillance in light of identifying that gene mutation. In addition, it might inform treatment decisions down the line should the cancer go on to progress. So again, as I mentioned previously, it helps inform if we have a more aggressive cancer, if we can safely pursue active surveillance. It can inform other family members of elevated cancer risk for them. And it can help inform risk of developing a secondary cancer. So it can help us to funnel patients to the right providers in order to start performing preventative screening should they have a genetic mutation. For advanced or metastatic prostate cancer patients, there's been waves of incredible new drug combinations that have come out for metastatic castrate-resistant prostate cancer patients that have shown great long-term outcomes for these patients if we identify these mutations and put them on the correct medicines up front. So it can qualify them, as it says right here in this box on the right, qualify them for advanced therapies like PARP inhibitors. It can qualify patients for personalized cancer trials. And just like I mentioned on the left, it can also help them to understand whether they're at risk for developing a secondary cancer. So how do I know if I qualify for testing? At Myriad, we provide one of these cards, as you can see on this right-hand side on the box, that allows you to qualify. There are a lot of criteria currently around prostate cancer. I am hopeful that one day prostate cancer will be afforded the same testing criteria that breast gets right now, which is if you have a breast cancer diagnosis, you qualify for testing. It's still a little trickier for prostate cancer, but we are making strides. So anybody with high risk or very high risk prostate cancer, regional prostate cancer, or metastatic prostate cancer qualifies. Gleason score 6 or 7 and one of the following. Y'all can read these, but anybody with Ashkenazi Jewish ancestry, anybody with family member who had ovarian cancer, pancreatic cancer, breast cancer less than or equal to 50 years old, etc., can qualify for testing. Keep in mind, it gets a little dicey. So Medicare also sets criteria for reimbursement. And sometimes Medicare will bring down the hammer and say that they won't qualify, or they won't approve testing for certain patients. So even though guidelines say that this is who can receive testing, there is sometimes a roadblock with insurance. However, I think it's important to be informed, should you meet this criteria, that you talk to your healthcare provider about it and see whether you can pursue testing. This is a short video. Do we have time for this? Sophia, are you on here?
Yeah, it's not a video. It's just a quote.
Okay, it's just a quote. I'm sorry. I didn't know whether we had incorporated the video. This is one of our testimonials from Ed Happy, a prostate cancer patient. He got testing and let me read exactly his background. So he was diagnosed with prostate cancer. He got screening with MyRisk hereditary cancer, and he discovered that he had a BRCA1 mutation. And he was concerned that he may have passed this on to his children because he learned from his provider that obviously his offspring would be at risk as well. And he took steps to protect his family as well and inform them about his mutation. And as a result, all of his children got tested, and his 2 daughters and 1 son, who are pictured here, also carried the same mutation. And so that afforded them the opportunity to start screening earlier for cancers that they're at risk for. Grandchildren also, once they become adults, can test for those same mutations. And so it becomes a cascade effect that now an entire family, because Ed decided to pursue testing, now an entire family is able to prevent their cancer risk, or and then inform the entire family and their physician network moving forward. Okay, so that is what we have about hereditary cancer testing today. The next section of our presentation is on biomarker testing in the prostate cancer space. So I'll move on to that now. Okay, so we have a test called Prolaris. Some of you might be familiar with it. It's a prostate cancer prognostic test. It combines tools like Gleason score and PSA, which, as I mentioned before, are the traditional ways that we risk stratify prostate cancer patients, meaning depending on what PSA and Gleason score look like, we say this is how aggressive your cancer might be. But we combine those tools with a personalized molecular tumor score. So we actually look at the genetic profile of the prostate cancer tissue itself to determine how aggressive the prostate cancer is based on the cellular turnover in the prostate cancer tissue. So it goes beyond the traditional methods of risk stratifying prostate cancer patients to provide a personalized risk for a patient versus just grouping them into a cohort of risk. So who is Prolaris for? It's for, we gave 3 examples over here, Bill, John, and Hector. Bill's 62, he's got Gleason 6 prostate cancer, and he wants to understand if he's safe to pursue active surveillance. Then we have John, who's 67, he's got Gleason 3+4 prostate cancer, and he's trying to decide if he wants to do surgery or radiation. Lastly, we have Hector, who's 70. He's got Gleason 4+3 cancer, and he's trying to decide if he really needs androgen deprivation therapy after radiation. So all of these patients can use Prolaris to help answer their questions that they have around treatment decisions. So as I mentioned before, it goes beyond Gleason for treatment decisions. Biomarker tests like Polaris, there are others on the market as well, are supported by major cancer treatment guidelines, and they make it easier for you and your doctor to tailor your cancer treatment plan specifically to you versus just grouping you into low risk, intermediate risk, high risk. It actually takes your individual tumor and determines how aggressive it is behaving. So it can help to answer questions like, what is my risk of dying from prostate cancer? What is my risk of the cancer spreading and metastasizing to other parts of my body? Am I safe to pursue active surveillance? Can I maybe not do active surveillance, but do I just need one form of therapy instead of two? Do I really need ADT? Can I maybe forego ADT because my personal benefit of adding ADT to radiation therapy isn't enough for me to undergo the therapy and have the adverse side effects that it brings with it? So as I mentioned, these are all questions that can be answered by biomarker tests like Prolaris. So what's needed to perform the test? It's performed on a very small sample of tissue from an existing biopsy. You have to be untreated to receive this test because we want to make sure the integrity of the tissue is untreated so that we can answer those questions accurately that I just mentioned before. So it's anybody with localized prostate cancer, newly diagnosed, or who is currently on active surveillance and has not had any form of therapy prior. This is another quote from one of our prostate cancer patients, Tim, who got a Prolaris test. And he said, the Prolaris test is personalized to me. It takes a look at the cancer and measures it in its individual aggressiveness. So as I mentioned before, instead of grouping men into cohorts and just treating them based on how they fall into a large group of men, and we make determinations for treatment based on just this group method, we actually are able to deliver a personalized approach because we are looking exactly at how the individual patient's cancer is behaving. Ordering testing early in the treatment pathway enables you to personalize patient care. So MyRisk, which is the hereditary cancer test, again, which tests for genes like BRCA1 and BRCA2 and colon cancer genes, other renal cancer genes. We have 48 genes on our panel, and all of those genes are actionable, meaning that there are ways to reduce risk for those genes that we identify. It helps providers understand if patients are at risk of developing a secondary cancer, can inform family members, as I mentioned, and it can help to identify personalized targeted therapies for prostate cancer patients as well. And then Prolaris identifies which patients are candidates for active surveillance versus definitive treatment. And again, as I mentioned before, if definitive treatment ends up being the recommendation, then it can also inform whether a patient can safely pursue just one form of therapy versus multiple, meaning adding ADT onto their treatment regimen. And it can quantify the benefit of adding ADT to RT, to radiation therapy. That is one of the new additions to our report because ADT is a hot topic. It kind of always has been. As I mentioned, I used to manage metastatic prostate cancer patients, and they hated ADT. It made them feel lousy and terrible. And both the short-term and long-term adverse effects are pretty impactful to the patient's quality of life. Testing is affordable. That's always obviously a big question. Medicare covers our tests at 100%. Greater than 93% of patients pay $0. Also, financial assistance is available. And in addition, we have several genetic counselors and medical information liaisons who work at Myriad who offer counseling to patients who receive our testing at no additional cost. It's easy to set up an appointment. This just gives some information about how to do that, whether it be a phone number or online. And if there are any questions that are not answered today or that may come up in the future, this is an email address that we are happy to get questions at, and we will answer through email. So that is what I have today. I will stop sharing now, and we can open it up.
Thank you very much, Christina. Thank you. I'd like to, oh, who's there? I thought I heard another voice. I'd like to go ahead now and move into the question and answers period. Dr. Glodé, would that be okay with you? I think.
Sure. Yeah, I just turned my mute off.
Yeah. By the way, reminder to everybody, the chat feature is on. You can send your questions in. Martin and I will be processing them for you. So please feel free to go ahead. One of the first questions I have is from Gary. And Gary has asked, is there a correlation between ovarian and prostate cancer? I'd also like to add, Dr. Glodé did comment on that in the chat, but perhaps Christina and Dr. Glodé, you could both answer that question. Christina?
Sure. Well, as I said in the chat, the BRCA genes, which are BRCA1 and 2, and maybe some others, but confer a risk for both breast cancer and ovarian cancer, as well as prostate cancer and a few others, actually. But BRCA1 and 2 are the main genes that Christine mentioned. And I think that the answer is yes. I mean, if you have one of those gene mutations in your family, you're at risk for cancers.
Yes. And if you have, there's kind of a couple ringers too. If anybody in your family had ovarian cancer and you tell that to a provider, that should be an immediate inclination for them to kind of say, okay, that's not normal to get ovarian cancer. So let's kind of dig deep and see if you need genetic testing. And yeah, as Dr. Glodé mentioned, also BRCA are the main genes. There are a few others that can confer risk of developing both ovarian and prostate cancer.
Okay, and I would like to just peek outside the envelope today. Perhaps Dr. Glodé would confirm this for us. Although Myriad is wonderful enough to be a sponsor and present this program today with us, there are other tests involved for these purposes. Dr. Glodé, would you care to comment on that?
Yeah, let me, am I able to share my screen, or do you have to give me permission?
Bill?
I think you can share without permission.
Yeah.
Host disabled participant sharing, it says when I try and click on it.
Oh,
You're able to do it now.
Okay, let's see if I can find the right place to go here. Let's see if I can share that one. Can everyone see that?
Yes.
Okay, so regarding some of the questions that have come up, there are guidelines, and this is the National Comprehensive Cancer Network. NCCN is a group of about, I don't know, it's 75 or 80, I guess now, comprehensive cancer centers that have been put together. So all the ones that you can imagine that are, often associated with universities and so forth, but it includes Sloan Kettering and MD Anderson and all those, and where I am, the University of Colorado, as a member. But there's 80 members or so, and they put together guidelines for cancer therapy. And this is kind of the Bible for cancer management. And I just went to the prostate cancer one, but if you go to this place, so you can, it's nccn.org. They have guidelines for each kind of cancer, and prostate cancer is one of them. I think that what I'll do is at some point in this, I'll try to copy these URLs and paste them into the chat so that everybody has them. And then, you know, there are a bunch of other pages that I wanted to bring out here to answer the question about which tests to use. Myriad is, as mentioned, one of several companies. And this is put together by the Prostate Conditions, I guess they call it now, Education Council. A couple of my close friends are on the board and stuff, and it's kept up to date fairly well. And it has all of the genetic markers from all of the companies. Now, keeping up, what I don't know is how well they're keeping up with that. But you can go over here, for example, and click on screening and early detection of prostate cancer, and it shows you the different markers that are available from different companies. If we go back and you click on the, let's say, who to treat. So this is more important for active surveillance patients. Here's, you know, that group of treatment options, or of testing options and so forth. So there are a lot of tests, and for the most part, there aren't a lot of direct comparisons. Which test is best? I think the best thing to do in that regard is to talk to your provider, your urologist or your medical oncologist or a genetic counselor about which test might be best for you. And you can click on each of these tests and download, and the companies have all provided information on the advantages, and or they usually don't provide disadvantages, but the advantages of their tests and so forth. And then you can get to the company websites this way too. This is Myriad's you know, website that Christine was talking about. And then just to show you that things are moving along very quickly, I thought I'd mention, you know, here's one. Grail is a company, I think they're in the UK. Lots and lots of ongoing controversies. They have a pan-cancer test. So looking at, I don't know, Christine might know, the 500 most commonly mutated genes in cancer in general. And it's not covered by the FDA right now. It's in kind of a research phase, but you can actually get this test. You pay for it yourself. And there are huge problems with thinking about whether you should get a test like that. So this is just for somebody who, let's say, oh, my great aunt had breast cancer and my uncle died of lymphoma, and I wonder if I have a cancer gene. And the problem with that is that there are false positives and false negatives. Secondly, if you have a certain gene, it doesn't necessarily mean you're going to get that cancer. And it triggers what Christine referred to as cascading. So you find out that you have a particular gene. Now you sort of say, oh, I have this risk for pancreas cancer. Does that mean I get an MRI of my pancreas every year? And there's no evidence that doing that does anything but add to cost. There's no evidence yet that using this kind of testing saves lives. It's very interesting, and there are anecdotes all over the internet about how, oh, there was an article in the New York Times, I think last week or 2 weeks ago. I got this test, lo and behold, I had cancer, it saved my life. Well, that's one story, but if you did that on 10,000 people, how many people would go through all kinds of unnecessary biopsies and have all kinds of anxiety and so forth? So that's a very complicated thing. So, but the world of genetics is just exploding, and it's hard to keep up with. But I'm hoping that those websites provide you a little insight into what's going on more broadly.
Thank you, Doctor. Christina, did you want to add anything to that broader perspective? I know your particular test had some particular features in it.
About like pan-cancer testing, or
your Prolaris test. I know we just did a whole spread of them. It's kind of hard to cover them all, but perhaps what Dr.
Sure.
Yeah.
Sure. And I know there was a question in the chat, like Polaris versus Decipher, for instance. Did you want me to go into that?
Well, I think if you know a little bit about it, sure.
Sure. So Polaris, first and foremost, appealing to this audience, was developed really initially to inform active surveillance decisions. So that is our big thing. All of our studies in that space have been developed on untreated patients because we wanted to develop a test that was trained on the patients to which we were trying to give treatment recommendations to. So that is one difference. A lot of Decipher has an excellent post-radical prostatectomy test because a lot of their studies have been done in that space. So if you get a radical prostatectomy all day, use Decipher. If you are really looking to see whether you can safely pursue active surveillance, Prolaris is your go-to because all of our studies in that space were done on patients who had not received treatment, which when you're trying to make an active surveillance decision, that's the patient you are. You have not yet received treatment. So that's
Good. Good. Thank you.
What's that?
Thank you. And I also wanted to emphasize, as Dr. Glodé and yourself have emphasized, always work carefully with your practitioner, your clinician, because she or he might have significant knowledge about your particular case. So I always like to be honest with you, side with the doctor and the clinician such as yourself that has experience in these things.
Yeah. And to Dr. Glodé's point, I mean, yeah, there are certain, obviously NCCN, sometimes we have to be careful about citing NCCN because typically you need permission from them, et cetera. So yeah, NCCN is the holy grail of oncology practice, right? That's what we reference. They set out the guidelines. There are 65 NCCN guidelines for different cancer types.
If I may, I'd like to interject another question. I'll be selfish and say this is from myself. But, years ago, before I had my genetic test, I didn't have an understanding. Could you tell us what is the difference between a medical grade and a more standardized genetic test?
Sure. So there are tests on the market like 23andMe, for instance, that they market that they test for BRCA mutations. And if you get like a 23andMe test plus the health, they'll run that for you. So that's their more expensive test. However, what they do not let you know is that they only test for 3 BRCA variants when we know there's well over 1,000. And the 3 that they test for are only specific to Ashkenazi Jewish patient populations. And so when you get what Geoff's citing as a medical grade test, you are receiving a test that is testing thousands of variants within a gene versus just one of these 23andMe's or Ancestries or whatever they may be that only test a couple and then tell you like, oh, you're not at risk. Well, that's not really a comprehensive picture of what's actually going on. So that's the difference. Also, within a report from a medical grade genetic test, you'll receive medical management guidelines that are drawn directly from NCCN. So we'll say you carry this mutation and this is what NCCN says that you need to do with that mutation. So
thank you. I have another question from Patrick. He's asking us, please define family member in terms of the genetic testing discussion we're having.
Sure. So NCCN breaks it down into like first, second, and third degree relatives. So just if you go down a family tree, like first degree is obviously going to be your parents, your siblings, your children. Second degree would be grandparents, aunts, uncles, etc. And then third degree would be like cousins and so on and so forth. Okay. So that's how they define it. And typically within guidelines, they'll give like differentiating, if you have these relatives, and then they'll specify what they mean by that.
Doctor, feel free to jump in here if you have any additional comments as we go through these questions.
Sure.
Okay, thank you. I have another question from Dale. It says his father had prostate cancer. Dale is Gleason 7, and he's asking, should he have a gene test?
I'm sorry, Dale has Gleason 7 and there's a family history, you said?
Yes, his father had prostate cancer.
Do we know what kind? Like what risk it was?
Gleason 7, I think.
Did he die from his prostate cancer?
His father, I don't know. I don't know. He didn't specify that, but maybe if you could just go with that, or perhaps qualify it as you answer it.
Yeah, so if you're diagnosed with Gleason 7 and your dad had prostate, if you're Gleason 7, but you have any high risk components, like I don't know what your PSA might be. If your PSA is greater than 20, then technically you do qualify. If your dad died of prostate cancer, then yes, you do qualify. If you're Gleason 7 localized and your dad had prostate cancer that he did not die from, then unfortunately, no. If you have other family history greater than or equal to 2 relatives with prostate cancer, so if it was like your dad and one other person, then yes. I would refer back, and I'll share those slides. I would refer back to that criteria card that I put up during the presentation, and bring that to your provider and maybe go through an extensive family history to try and kind of meet criteria.
Okay.
Because just with that alone, unfortunately, no, unless I knew more information about your dad's prostate cancer or your prostate cancer.
Okay, so basically, we're also saying the broader picture, the other biomarkers is work with your clinician and your doctor. Is that right, Michael?
Well, this gets into like what we talked about at the start. Don't necessarily rely on anything that we say. Talk to your own doctor about this. I mean, the big picture is that you have to look at a lot of things. So one Gleason 7 cancer, what if you have a Gleason 7 cancer in 8 out of 10 biopsies? That's different than having a Gleason 7 in 1 out of 10. And
Right.
if you have, like Christine was saying, your father died, that puts you into a category that you might have the lethal phenotype. I think that the markers, are helpful in sort of a generic way. Like if take the person who has a very small one biopsy with 1 millimeter of Gleason 7 cancer, and then you get into, okay, well, would a biomarker help me decide whether to treat that patient? Or in my case, I'm a medical oncologist. I don't do primary surgery or radiation, but I do a lot of consulting with people. But that's where the markers can help. So a person with one small area, you might not get a marker. Well, what if they have 2 small areas of Gleason 7? Then you say, oh, well, maybe that one of the genetic tests could help. And if you are familiar with a genetic test that you've used and you like it a lot, and you order that, and it comes back that patient, even though it's Gleason 7, is at very high risk from a genomic point of, or genetics point of view, and that's somatic genetics, that's the tumor itself, that you might tip the scale and say, yeah, I'm going to do that. Or if the patient has a PSA of 23 at the start, and that's in the guidelines. So, and they're in those guidelines, you can, if you search through those, and you have access to those now, I put in the link, you can sort of see what constitutes high risk versus intermediate risk versus low risk. And the markers are not perfect. It's a Rorschach test, right? Some patients, given a certain profile with a score of that puts in the middle. I guess the most common way that I have seen things is you have a patient who's got a Gleason 7 and it's sort of intermediate risk. They've got 2 biopsies. You say, well, I'll send off a marker. And it comes back, yeah, they're sort of in the middle. It may not help make a decision at all. And I always tell the patients that before we send off markers. It most likely will come back telling us about what we already thought. But in those cases where you get an extreme, that can tip your advice, right? So somebody you thought was at, average risk, but it turns out they're at very low risk genetically, then you might be more inclined to say, yeah, let's just watch this for a while, and vice versa. So you have to look at the whole picture, including the family history and all of that to properly use these tests.
Thank you.
And I'd like to piggyback on that. Family history is specific to hereditary cancer testing. So when we're talking about biomarker testing in the sense of sampling the prostate cancer tissue itself, family history is not involved in that. That is specific to you and your cancer. So I think that that's an important differentiation. Since we presented kind of two ideas here, right? Hereditary cancer testing and then genomic testing on tissue. Keep in mind that Prolaris has nothing to do with family history, whereas our MyRisk test or other genetic tests, family history is important in those decisions. So
and getting a genetics counselor involved. Unfortunately, we don't have enough genetics counselors. But we, and those guidelines mention that genetics counseling is now strongly recommended and indicated in a lot of cases, and so forth. I have, just another kind of personal example. My father died of leukemia. My mother had breast cancer and colon cancer. One of my sisters has had breast cancer. So I've seen the genetics counselor. I've had a test that has about 125 genes in it, and none of those showed up with anything. And I had prostate cancer. So somewhere in our family, almost certainly there are probably a series of genes, more than one, that have each one of which contributes a low amount of risk. But put them all together, and then the family ends up with, being a cancer family. So that's kind of a really interesting thing. And there's all kinds of very sophisticated statistical things that go into deciding which tests, which counts as a cancer gene. But a lot of genes that can give you a predilection to cancer have such a small impact themselves that it takes more than one of those, plus the environment. Did my father smoke? Did my mother, in my case, my father was a machinist and washed his hands in benzene every day before he came home to get the grease off. And that's a known carcinogen, right? So there are all kinds of things go into it, but genetic counseling is really helpful. And if you have, a family history that you're concerned about, I think that's the first place to go. Most of us clinicians have, some knowledge about it, but we don't take the time to really lay out the whole genetic tree and look at it and say, oh, this triggers that panel of tests. And that's why genetic counselors are so valuable in this field.
Thank you, Doctor. We have several, this is another question. We have several Canadian, European attendees, and maybe we should open this up to an international perspective for both Christina and Michael to answer. Dr. Michael, in terms of, can some of these tests be used across the borders? And I must make a personal disclosure about myself. I do write for Prolaris as a blog writer, but being open-minded, I'm letting you know that. I don't take any particular side here. I wanted everybody to know that.
Yeah, I'm not an expert on, for example, the UK criteria for getting these tests paid for. The tests themselves can, Christine can maybe talk to it. They can cost $500 to $2,500 or in that range, I guess, something like that. I don't know. So they can be paid for out of pocket if you're in any country. I guess you have to have a physician or care provider in Canada or somewhere who is willing to help you get the blood drawn and or send off the tissue. But I don't have an idea. I don't really have an idea as to whether if you sent tissue from South Africa to Myriad, whether they are willing to test that. I don't know.
It's a good question.
So we do have go ahead.
Go ahead, please.
We have an international team, so we do, I could link them to our international team because we do have like a Polaris international face. As far as like Dr. Glodé said, no, you can't send tissue across the country. It doesn't work like that. It would have to be in the specific country. And then as far as Prolaris is concerned, it's more expensive from a direct pay option versus hereditary cancer testing. Direct pay is $250. Otherwise, like I said, coverage is incredible if you have Medicare or private insurer. But if there, you know, I know y'all mentioned that it's like 30 countries that you have following y'all, so we can give some information for our international team if that would
And
be helpful.
I think most of the, I think if you went to the websites of the various tests, they probably have contact information where you could write and ask how would I get a test done? How can I send tissue? How much would it cost me? That sort of stuff. I think that's
Yeah.
probably company by company and country by country in terms of availability.
Yeah, yeah. And doctor, would it be appropriate? I know doctors, especially in their clinics, have plenty to do, perhaps too much on a daily basis. Would it be generally okay for patients and doctors to ask Myriad about this question where that makes sense? Contact the manufacturer, if you will.
Yeah, I mean, I think that's exactly what you should do.
Okay, save everybody a little bit of problems. Let's see.
I can add maybe because I live in Toronto, so I had no problem of getting genetic tests covered, and I have like 2 brothers passed away from prostate cancer. So I got 19 different genetic genes tested for mutation. As for the genomic tests, I was told that it could be done while during the pathology time when the pathologist works on my sample. If they decide to do genomic tests, they would do it at that time already. Or later on, but they would consider genomic tests at the time of pathology.
Yeah, and that's a good point. I would just say that a lot of cancer centers, big cancer centers, have the ability in their pathology department to do detailed genetic testing, sequencing that is not done by any of the companies, or is done in addition to the companies and so forth. And some of that's done on a research status. But for example, at our cancer center, we have COMOCO, the Colorado Molecular Oncology, division within the pathology department. And if you have something that doesn't make sense, they dig into it in great detail as part of just quote unquote routine pathology workup. So that doesn't involve a company at all. And so if you're in a major cancer center anywhere in the world, very often that kind of stuff is available at the cancer center pathology department. In addition, and they work hand in glove with the genetics counselors in that particular institution.
Okay, I'd like to mention that our guest speaker, Christina, has to leave in just a few minutes. So if there's any particular questions of her, please provide those now. Otherwise, Christina is going to be hopping on to her next assignment, probably her family in lovely Louisiana.
Thank you for having me. Everyone enjoy your weekend. And I told Geoff I am available for questions by email. We provided an email in the slideshow. So if there are any questions that remain unanswered after this, I'd be happy to answer them.
Okay, so
thanks again.
Thank you very much and have a great day. We're going to move into the next part of our program, a little more open. Martin, are you with me today? Martin,
Yes,
you join on. Do you want to go live, or do you prefer people continue to use the chat box for additional questions?
I think that's your call. I think if people want to raise their hands, they find the raise hand feature at the bottom of the screen. I think that then could be
okay,
something that we could do.
So let's be good and polite, gentlemen. This is not a rugby game, although it can be at times. We'll try to avoid that. Or hockey, being from Montreal myself, I have my preferences, but I won't mention American football. Let's get into some questions. Please put your hands up. Okay, Martin, you can help me. Do you see? I don't see any hands going up yet. And Dr. Glodé is still with us. He's going to help out. Barry Siegel. Barry, go ahead, fire.
Yeah, I just finished reading the New England Journal's 15-year outcome of monitoring surgery or radiation for prostate cancer. Pretty eye-opening study. And I was wondering if anybody had the chance to review that, and I'd like some comments on what their thoughts are on that finding.
Okay,
Well, I could speak up about that. That's the PROTECT study. And it was a 15-year review. It came out about a year ago in New England Journal. And what they were looking at in part was an early version of active surveillance. They called it active management. And they followed people for 15 years, but the results are kind of consistent with Dr. Klotz's studies up in Canada. Basically, what it comes down to is it doesn't matter whether you go on active surveillance or if you have surgery or if you have radiation therapy, the mortality or the death rate at 15 years is about the same. So, in guys with Gleason 6, for example, it kind of comes down to, if why not go on active surveillance and avoid the side effects of the other treatments, unless you have some sort of, like emotional distress about it. So, I mean, Barry, that's what I got out of that.
Thank you, Howard. Dr. Glodé, would you like to add to that, please?
Yeah, well, in general, I think all of us in the prostate cancer world get too wound up in getting treated or, making a big deal. For any individual, it's of course a huge issue, right? And we think that we're going to die of prostate cancer and all that sort of stuff. I mean, here's the reality, right? Can you see that?
Yes, sir.
I mean, we all forget this, and there are really no large, properly randomized trials where people were forced into choosing one versus the other. And so any individual making a decision is often influenced more by what happened to their relative or their buddy at work or whatever else. Oh, he had surgery and he did fine, so I've decided on surgery. And then, people in this group might say, well, I'm doing fine with active surveillance. But, in a sense, it doesn't matter. Now, having said that, obviously the deal is picking out the sheep from the goats or the rabbits from the birds or whatever one of those many overused analogies you want to do. But, the big picture here is that, here at 17 years, 95%. So most people die of other things.
Yeah.
Regardless what it is. So, and the older you get, the more likely it is you will die of something else.
Thank you.
So that, and what your own baseline health is. So, this just, I think that's the big picture from that article.
Doctor, you mentioned your father working in the machine tool business. I'm always concerned about exposures. I mean, we all get diagnosed and perhaps on active surveillance, and then we walk into a plastics factory or we get sprayed by a pesticide plane. I mean, I guess there's always a chance that we're going to trip ourselves up and get some exposure. Is that not true?
Well, you're exposed to stuff every day. Who knows what about the plastics in our drinking water? I don't know. It's true, but there are things you don't do. Smoke.
Yeah.
And and you don't wash your hands in benzene every day. So
my dad was in the same business. That's why I had to go.
And
thank you.
In terms of active monitoring, this is another important figure from that article. Patients start falling off the wagon for one reason or another. Either their Gleason score changes and gets more aggressive, or they have more biopsies positive, or their PSA changes and has a curve that goes hockey stick. And so, by 10 years out here, about half the people who are on active surveillance have gone ahead and had some sort of therapy. So that's a reality. And it's fine, but you can make the argument, okay, well, during this whole time here, guess what? They weren't incontinent and they might still have been able to be potent. So, there are advantages and risks involved, but it's for everybody to educate themselves through organizations like this and make good decisions for themselves.
Thank you. Thank you, Doctor.
I got to run for just a second and help my wife with the car. I'll be back.
Okay, thank you, Doctor. Here, I have a question from Brandon in West Palm Beach. This is on the chat. Is there an alternative monitoring care aside from biopsies?
Well, how about MRI for one?
Yeah. Yeah, we've all been through that. Some recent articles on combining MRI. Howard, did I not see something about PSMA this morning from Europe? One of their.
I didn't, but maybe you did. But
Yeah,
there's controversy over was it prostate specific membrane antigen, and there's just a lot of guys want to have it done, but generally the system is resistant to doing it on guys with Gleason 6. It's expensive and not considered necessary depending on who you talk to. On the other hand, some guys with low-grade prostate cancer, more guys with intermediate risk have it done, and they're relieved to know that the cancer hasn't left the prostate capsule. So I don't know what you read, Geoff. Maybe there's new news.
Yeah.
Guys, I just want to interject something just to clarify what Brandon may have been getting to, or Gordon, that the tissue, the current tissue biopsy is the only diagnostic tool for prostate cancer. Of course, there are varying variables in terms of the AUA guidelines suggesting that the monitoring option of active surveillance include a regular PSA and followed up by a biopsy every several years. Many choose to also have the MRI after the PSA to actually determine whether or not they should need a biopsy, and that determination is always made with their medical team. So I just wanted to clarify that point.
Well, AUA in particular says that MRI is a good idea if it's available. It's not, prostate MRIs are not available everywhere.
Yeah, so it's kind of a large piece of equipment. It's not like just working with a drill in your shop.
And there's a big issue with interpretation. A lot of the radiologists are not well informed or skilled in reading these things. To most of us, they look like mush.
Well, Howard, maybe we could do a little salesmanship here on the next program, which I know you'll be involved in, AI. Do you think AI is going to help improve some of these readings of slides and other biomarkers?
Yeah, there's a lot of controversy about it, although in general, there's a feeling that AI is going to have its biggest impact in medicine. And I noticed one of the guys on today is somebody who had the Artera AI test, which is AI that looks at images and can predict whether men need androgen deprivation therapy, ADT, which has horrible side effects. Artera can rule out the need for ADT in about 2/3 of men. I don't know if Greg has something to say since he's had it. There's another group in Michigan that is working on an AI test that'll help men decide whether they should go on active surveillance. So we're going to have this program in a month on AI. I hope you can all come. It's not far off. It's being used. The Centers for Medicare and Medicaid Services a couple of weeks ago approved reimbursement levels for Medicare for the Artera test. And so, you know, it's happening. What can I
Okay.
say? I don't know if Greg wants to chime in because he's the guy who's actually had the test.
Let's see if we can't get to some of the open hands. Somebody with an open hand, you want to unmute yourself and fire away?
Yeah, I'd like to ask a question in reference to where can I find the 7 items that were mentioned for the Polaris testing thing? It started out with Ashkenazi Jews and minority groups, but I missed the other 5.
Okay.
Where would that be located?
We should have a link on the, I believe Christine left. But let me see if you want to text one of us or email one of us. We'll forward that on for you.
Give me an email address, please.
Yeah.
It should be on their website.
I looked at the website while everybody was talking and couldn't find it. You know, I didn't do an in-depth search, but I did look for it and briefly just scanning quickly, I couldn't find it.
All right. And you're talking about the Myriad test, right?
Right, yeah, the Polaris test, I think, is what it was under.
Yeah.
Yeah, I copied that slide. There are 7 or 8 things on there. I could dash them off quickly.
Martin,
do I qualify for testing?
Yeah, I'm looking for that. I thought she posted that.
Ancestry, family member with a high risk or metastatic.
So,
Well, I copied it. A family member with ovarian. There's just a couple more. Family member with pancreatic cancer. Family member with breast cancer who was under 50, at 50 or under 50. And the final one is 2 family members on the same side of the family with breast or prostate cancer at any age.
I think I got most of them. Thanks.
Okay. All right. We have a site, sir. You can always send your question directly to the ASPI site if you haven't seen it before. Who else has got their hand up? You want to jump in and ask a question? What?
Hey, Joe is raising his hand.
Okay.
I just wanted to weigh in on some, we already passed this subject, but I'm a US citizen living in Canada and I was seeking genomic testing. And because I have Medicare also, well, not just because of that, but I went for a consult in Seattle and a Prolaris test was ordered by my urologist there, but they could not, I think it was indicated by the lady who was speaking, I can't remember her name, but that Prolaris would not order the slides through Vancouver. You know, I had my biopsies in Vancouver. And so I ended up getting a Decipher test. So Decipher is a option for Canadians because the office is in Vancouver, you know, so I just want to weigh in on that.
Yeah, but does your health plan in Canada cover this kind of testing?
No, yeah, that's the other thing, because my Vancouver urologist also wanted me to get a Decipher, and I said I was going to pursue it through the US, you know, getting a US doctor and Medicare to pay for it. But in Canada, it is not covered. And I think it's 3,800 Canadian for the test. And I don't think there's, so I did it through the Medicare and I just had a small copay, you know.
You were able to do it then, huh?
Only because
Decipher.
He's dual, yeah, he's an American citizen.
Yeah, only because I have US coverage also. And I have permanent residency, so I have coverage in BC. But that coverage it excludes the genomic testing.
Well, and I'll just add in general, if you get to the company, you could go to that place that I published, or not published, but I posted there with the websites for the different tests. If you click on the test and first talk to your urologist, talk to your care provider, which test do they recommend and why? But a lot of the companies have patient assistance plans. And one of the reasons for that is that the reality is there's a very high profit margin in doing tests, just like the $10,000 a month treatment options. And so the companies are very anxious not to have patients writing into their congressman or whatever about going broke. So they are all very profitable in general, and they would like to not have bad press about how much their tests or how much their drugs cost. And for that reason, they are very willing to provide patient assistance for things that are needed. So I think if you really wanted one of those tests, you'd probably find out that somebody's willing to help you get it paid for, even if you live in Zanzibar.
Thank you, Don. I have Joe. Why don't we allow a few more, and then we can come.
Sure.
Joe.
Oh, no, that's okay.
Another Joe and Bibbo. Joe, would you please fire away?
Understand why the PSMA test is not given for active surveillance patients. I talked to my urologist and he said it's expensive, yada, yada, yada. But if it could tell you right off the bat if it's spread beyond the prostate, because a lot of this prostate cancer is not visible for years. My cousin had his prostate removed, and 5 years later, they found his PSA was rising. They did a PSMA and they found exactly where it was. They went in there to do a biopsy or to take it out, and they couldn't find it, when they went in. And now he has pancreatic cancer. So it's like, if they give you this test right off the bat, they can tell you if it's spreading somewhere before it becomes a tumor. I mean, that's my take, but maybe I'm incorrect on that.
Dr. Glodé, could you?
Yeah, you could do a whole a whole session on PSMA. So let's just define the landscape for a second. PSMA stands for prostate specific membrane antigen, and it was discovered in the late 80s, but definitely in the 90s. And there were antibodies made to it, and you could use the antibodies and put radioactive stuff on them and try and treat prostate cancer and all that. And it turns out that in the last decade, or maybe 15 years, much more was learned about it, and people were able to develop small molecules that could be tagged with radioactivity and make a very sensitive scan that's much more sensitive than the standard CAT scan and bone scan. Using it in people who are newly diagnosed will probably become standard of care over the next 5 years, at least for people at high risk with, high Gleason scores or high PSAs and that sort of thing. And it will help. It's definitely a very exciting time for that, but integrating it into when to use it, and it is expensive. It's like $4,000 or so. So getting it paid for by Medicare and insurance is one of the ongoing challenges. And you have to sort of say, well, how much difference does it make? And in my opinion, it'll make a big difference in high risk patients, because if you just had 1 or 2 metastases, you might still get your prostate treated and treat 1 or 2 metastases with the idea that you can be cured. That's called oligometastatic disease. So it's absolutely changing the landscape. But it's not a genetic test. It's an imaging test.
Right.
And if you hook really strong radioactivity to what's called the ligands, there are 2 or 3 ligands, meaning that there's a molecule that binds to a receptor, then you can use PSMA as a target and treat prostate cancer with PSMA therapy. And that's a hot area that's being, it clearly works when everything else has failed to work. 50% of people get some additional benefit from PSMA therapy, PSMA directed therapy. And so now most of the clinical trials that are underway are looking at, well, what happens if we use it even earlier in high risk patients and so forth. So it's a great story. It's not necessarily relevant to, to this discussion of genetic testing, but it's absolutely something to keep an eye on. And I would also say that, that coming back to the issue that you mentioned with your, well, some of you guys were discussing MRIs. The MRI is probably, in terms of just looking at the prostate itself and how big the tumors are and all that, it's probably the best test still, even better than the PSMA in some cases, but eventually people will combine all these. But the MRI really can tell you sometimes, even if the PSA is not elevated, oh, there's a spot that looks like it's high risk and probably would be cancer if we biopsy it. So there was a Lancet article 6 months ago about using an MRI for screening rather than PSA testing for screening, or at least combining MRI and PSA as a screening test. And it definitely adds additional information. And, you know, in my opinion, people should have MRIs before they get biopsied. If what triggers the biopsy is a rectal exam or a PSA, in my opinion, the next test should be an MRI. And I think most people agree with that.
Thank you, Doctor. In the interest, we have 2 more hands left. Before we do that, I'm the fundraising chair, so I'm holding up an ASPI mug here. For anybody who sends in $150 or more today, we're going to send you an ASPI mug. Sorry about the salesmanship, but you know, the bottom line of running an organization, you got to have some revenue. So that's enough of me. Ryan, you have your hand up. Would you like to shoot away, Ryan Sturkenberg?
Yeah, good afternoon, and thanks for the presentation today. Can you comment on the EpiSwitch prostate screening?
The tactics with prostate screening?
No, EpiSwitch.
Oh, the EpiSwitch.
PSE prostate screening.
Okay. I don't have a direct knowledge of that, Doctor. Will you help us out?
No, I don't know what you're talking about.
Well,
okay.
I mean, I can try and look it up real quick if you want, but
it was in the Urology Times, and they're saying that it's significantly more accurate than a PSA. And
EpiSwitch?
Oh, yeah. Okay. I think it's one of the newer ones. I wonder, is it approved yet, Ryan? Do you know?
It seems to be. Yeah, in September, it seems to have been approved.
Okay, and that's
according to what I've been reading.
U.S. or Canada?
U.S.
Okay, all right.
Yeah, it's just clinically validated for U.S. and for active surveillance. I didn't know if there was a prep, you know, but obviously it doesn't sound like we know too much about it quite yet.
It underscores the point that we're here, gentlemen. This science is changing every day, be it genetics or testing, diagnosis. It's amazing. So I encourage all of you to come back and listen. Ryan, you know, it just goes to show we're not know-it-alls here. We'll work as hard as we can to get back to you and see what we can find out about this.
You can do it in real time. It's I just looked it up here. I'll share my screen if I can find the right screen to share. I think it's that one. So that's it. So just to put a little bit of science to it. So it's got a PSA score. So, and it's looking at 5 epigenetic markers. So when I mentioned earlier that my family history has probably something going on in the genetics area, these are genes, each one of which in a research study that, you know, you'd have to look up and go back 10 years and see how they developed it, all have some ability to contribute to prostate cancer. This is, you know, microRNA, and these are 4 other genes, and they are modified epigenetically. Epigenetically means the DNA sequence is genetics, but if you look at what happens to proteins or RNA after the DNA is transcribed into RNA and protein, that's called epigenetics. So these are genes and or proteins or whatever that are modified after the sequence is transcribed in the gene, and they've been found to relate to prostate cancer. And so what happens usually is you use a huge statistical computer to start sorting through epigenetic changes, and a lot of times it's called methylation. So the gene itself has a carbon group attached to it that makes it more or less expressed, et cetera. It's really fun. It's complicated. But anyway, so this company apparently has taken a bunch of these markers, worked through a bunch of things and saying, oh, by combining this with the PSA score, we are more accurate than just using the PSA itself. So, and down here, it had a specificity of 97% and a sensitivity of 86% compared to PSA alone. So that's terrific. And that's how fast things move. And, then if it's now been approved and so forth. Now, the question is for people in this group that are interested in active surveillance, how good is this particular test at telling you, A, are you going to have progressive disease, or B, do you have cancer at all? And I'd have to dig into it more than we have time for right now, but that's how things can go. And I think that's the kind of thing to keep an eye on, but I don't have any ability to comment on whether it's something that would be useful for people on active surveillance.
All right, everybody, I'd like to jump in. The good doctor who lives in Colorado is an avid skier and he's got grandchildren. So I bet you his wife is waiting down in the car. Is that true, Mike?
No, she took off. She didn't know. She wanted to know how to read one gauge.
I better send you a set of golf balls then. Sorry. Anyway, gentlemen, I want to thank particularly the doctor and our sponsor, and as well as program presenter Myriad and Christina and all the good people here, particularly the ASPI. We're all volunteers. And I wasn't kidding about the mug. This is a great mug. If somebody comes over your fence at night, you can defend yourself with it, but it's mainly used for coffee. I thank everybody here today, and I want to encourage you to keep an eye out for our next program. Howard Walensky, erstwhile writer, terrific writer, science writer from Chicago, is going to be heading up that program in active AI. And it's going to be incredible because everything that's digitized, suddenly we're going to be able to start what I call slicing and dicing and taking information. And Lord knows where this is going. It's much more than my microchip can handle. Mark, did you want to provide any adios for us?
No, well, yes, adios. But great job, Geoff. Good program. Mike, it was good to have met you in person now, and sorry to keep you off the slope today. And I'm really looking forward to the next program on AI. So we hope you'll all join us next week or next month, I mean. And so we bid you farewell. Thank you for attending today.
Thanks. And thanks to our neighbors in Canada and every place else in Europe and the East and the West. We love you all.